And I just want to mention one thing, if I could, Stephen. There's some new research that came out from the University of Rochester just this year in January, and they found a new layer in the brain anatomically, and it's called the SLYM layer, or it's called subarachnoid-like lymphatic membrane. And it's a layer that's only about a few molecules thick. It's in between the subarachnoid space, which in craniosacral is an area where we're really looking to see if we can find a flow in cerebrospinal fluid. And what's interesting in my model, which talks about inflammation and a lowered flow of cerebrospinal fluid, is that if we can actually affect that layer seems to defend the immune system from having invaders cross and causing neuroinflammation. So it's a new area that's been discovered, which is kind of the area we've been treating for some time. And I think that might have to do with a lot of results that we're finding. So yeah, mediation of immune system processes could end up in the brain being compromised, but then we want to go backwards and find out what's the origin of the dysfunction in the first place. So sorry, I just wanted to jump in there and mention that as well.
And if I could piggyback on that, so we are talking about a response that we as organisms make to these different insults. This is the bottom line. It's about the insult and the response to it. So let's take a specific example. You've probably seen in the last few months, it was shown that Epstein-Barr virus is a common cause of multiple sclerosis. And in fact, about 94% of people have been exposed. So a lot of us have Epstein-Barr virus. It's very common. Anyone who had mononucleosis, for example. So you take 1,000 people, let's take 1,000 people at random. 940 of them will have been exposed to Epstein-Barr virus. 1 out of 1,000 will develop MS. So what we need to understand is, yes, Epstein-Barr is clearly important, but what was different about that one person's response than the other 939 that got it but didn't develop MS? Well, the numbers are a bit different with Alzheimer's, but it's the same idea. You take a same 1,000 people, about 150 of them are going to get Alzheimer's. Unfortunately, it's much more common than MS. But there are different insults that are associated and your response to those insults. So there will be some people who are going to get, for example, leaky gut, but will never get Alzheimer's. Some people that'll get changes in their oral microbiome, but never get Alzheimer's. But for those 150 people, it is the insults, the response to them. And you're kind of alluding to earlier. So what do we do about this? Well, these responses have to do with your genetics. If you are ApoE4 positive, you make a higher response, which is great for if you're living in a third world country. You can, eat meat full of microbes. You can have all sorts of, you can get, you can puncture your feet. You can do all sorts of things and you'll fight off the problem because you have this hyper-inflammatory response. But over your lifetime, this contributes to cardiovascular disease, slightly shorter lifespan, and a markedly increased risk for Alzheimer's disease. So everybody should find out what their genetic status is, and again, get on active prevention. So these different insults it's the response to those. So yes, we want to dampen the response, but we also want to remove the ongoing insults.
And if I can comment on that just a bit. It's like when we look at genetics and we look, some people have 1 copy of the gene, some have 2, some have 3. It puts people at greater risk. I think even Dale Perlmutter has 1 copy, I think he said. But the idea is the more you can mediate that, you just have to be more cautious and more careful. Yes. And that's the idea. So if you can find out what the precursors are, what's causing a problem, then you can kind of mediate that. It doesn't mean a death sentence just because you have the gene, but you have to be more careful because the immune system is going to be less responsive if there's those kind of insults. And one other thing I'll just mention, at a recent conference at the Upledger Institute, we had Stephen Porges, who's kind of developed polyvagal theory over the years. And he talked about the ventral and dorsal part of the brainstem, how it affects the rest of the body, what that is in terms of brain response, and how we can mediate that with various therapies. And that's a key physiologically. We can do with manual therapy something to actually lower that stress level and that response, which is automatic, that stress response, and break up that pattern. So it's all very intertwined in terms of the way our basic physiology and genetics responds to these kind of challenges.
And if I could just add the number of people in the United States, because it's important for people to understand, this is not an uncommon problem. So you mentioned 0 copies, that's 3/4 of the population. So for example, I checked my own, I'm an ApoE33, which is just the most common. So my genetic risk for my lifetime is about 9%. It's not 0, but it's not too high. If you have a single copy of ApoE43, that's 75 million Americans, and most unfortunately don't know about it. Your lifetime risk is right around 30%. And if you have 2 copies, that's about 7 million Americans, your lifetime risk is about 70%. It's fairly high. So everyone should get on active prevention. As Michael said, that doesn't mean you're going to get it. There's a lot you can do, and there's a wonderful website called apoe4.info that was founded by Julie G., who herself has 2 copies of ApoE4 and actually had some cognitive decline and is doing well now, 11 years into treatment, still doing very, very well. So there's a tremendous amount you can do about it. Everybody should know their status. Everybody should get on active prevention.
What about nutritional supplements? Brian Clement always says that everyone should take B12. That's very important for memory. Other people have said take DHA, EPA. Do you have nutritional supplement recommendations?
Absolutely. And it depends. You want to optimize your biochemistry. So if your B12 is 1200, I don't think you need B12. If your B12 is 200, you 100% need B12, or you could die from pernicious anemia. So it depends a little bit on what your levels are. But yeah, some of the ones I tend to like, the methyl Bs, things like methylated B12 and folate, P5P. I like whole coffee fruit extract because of its increase in brain-derived neurotrophic factor. I like magnesium. Most Americans are deficient in iodine, in zinc, in magnesium, in potassium, in choline. So I like all of those. Many of us not getting enough choline in our diets. So all of these things are critical. And by the way, choline is a precursor for acetylcholine, which is important for memory and which is low in Alzheimer's disease. So those are some of the supplements that I like. And then, of course, vitamin D. Many of us are deficient in vitamin D, and that's all been shown many, many times. Low vitamin D is associated with increased risk for cognitive decline. So all of those, I think, are very, very important.
And Stephen, one other point, you look at all these disparate things, they're like all factors that can contribute. Fair enough, right? But then you kind of want to look at the underlying physiology and how it's supported. Like one of the things that manual therapy technique like craniosacral does, and this may seem a bit non-medical and non-scientific, but it allows people to kind of tune in more to their inner wisdom, or what my mentor, Dr. Opledger, called their inner physician. Like recruiting and giving them the intuition to kind of find a way to optimize their health and their longevity. And in a way, what we're both saying is that really what we want to do is stack the cards as much in someone's favor as possible and use all the modalities that are going to really put people in a position where they can maintain their health and prevention, which is the key thing. If you can work on prevention first without things developing to a more extreme stage, that's so much the better. And with a number of people that Dale mentioned in the U.S. population that have even one copy of this disease, that's tens of millions of people. Yeah. And Ken Duckwald, who was one of the speakers at American Society of Aging, he mentioned that by 2030, something like at least 1 in 5 of the U.S. population will be 65 years or over. Like it's a significant part of the population. So what do you do when you have that many millions of people? And like Dale said, it's like COVID gave us a little bit of a preview of what happens when the hospitals are overwhelmed in a very short time frame, over weeks or months. But think of what's going to happen over decades when a large amount of the population may be in advanced stages. Like, what does that, suggest to the medical community and the economics of the situation? It's like something has to be done different to get the word out to support people.
Yeah.
Rita, would you like to ask a question, or where are you from?
Yes, yes, Stephen, thank you. Could you hear me?
Yes.
Uh, I, I'm Rita Batija, a functional medicine practitioner from the Baldwin Harbor, Long Island, New York. Dr. Bredesen, I really admire your work, and I'm so happy that you are opening up and people are listening from you the importance of the fat, which is there is a stigma that go for low fat, low fat, low fat, which is not important. I have a question for you. For the maintenance basis, the organic MCT oil, at least 1 tablespoon a day, should be taken with omega-3 fatty acids, EPA, DHA. So focusing on the DHA or the EPA. And the third one is a phosphatidylcholine complex, especially for the brain. So if you can comment on that, would appreciate.
Well, I would agree. I mean, basically, the one issue with MCT oil, you have to be careful. As you know, some people with either MCT oil or coconut oil will run up their LDL particle numbers. So unfortunately, they can have too much of the small, dense LDL, the oxidized LDL that can be atherogenic. So at the same time, it can be very helpful in terms of helping people to get into ketosis. So one of the things that I like that Dr. Ann Hathaway has done is to suggest that people combine that. So you have some MCT oil, and you mentioned a tablespoon. That's a very reasonable amount. Some people take a tablespoon 3 times a day. You can go by, where you stand with your ketone level. You want to get that ketone level up to 1.0 to 4.0, anywhere in there. As long as you can get it above 1.0 millimolar BHB at least once per day, or if you prefer to look at acetone using a breathalyzer, you need to get it up to about 10 ACEs per day, sometime during the day. Then you're going to be doing the right thing. And so combine that, but make sure that you don't have a high LDL particle number, and especially if you are ApoE4 positive, especially if you have known cardiovascular disease, be careful. Don't give yourself atherogenic particles because that can hurt you in the long run. Completely agree with you about EPA and DHA. And people, we're starting our next trial now. And what people are typically using 1 to 2 grams of EPA and DHA per day. And then phosphatidylcholine, absolutely, for multiple reasons. So all of those things are very appropriate.